I want to start off by welcoming two of my colleagues. They're going to do a tag team effort here. Marjan Farid is going to talk about the clinical aspects of clinical cross-linking, and Jamie Jester will talk about the basic science updates on this. So can I welcome Marjan? Thank you.
Let's say good afternoon. Thank you for being here and joining me for the afternoon session. So Dr. Jester and I will do a little bit of a tag team, as Eric mentioned, talking about corneal collagen cross-linking, which is probably one of the best examples of recent bench innovation that has really resulted in a profound difference in terms of clinical changes to a disease process. So let's talk about it a little bit. Corneal cross-linking is a process where we can stiffen the corneal tissue by creating additional collagen links between the bonds between the collagen fibrils of the cornea. First studied in Europe at the University of Dresden in the 1990s. Essentially, we combine a process of using ultraviolet light with a photosensitizer, in this case riboflavin, drops on the cornea that soak into the cornea, and then the UV light creates this additional links to be formed. And it stiffens the cornea. It results in shortening and thickening of the collagen fibrils and stiffens the cornea. So why would we want to stiffen the cornea? Again, this has been going on since the 1990s and is now essentially accepted as a standard of care for the treatment of keratoconus and corneal ectasia. So keratoconus is a process, it's a bilateral progressive corneal ectasia that results in irregular astigmatism, loss of visual function, and distortion of the image. Usually the onset is in the teenage years, and essentially the cornea, which is the outer layer of the eye here, develops this sort of irregular shape. It becomes biomechanically unstable and can result eventually in the need for a corneal transplant. Again, the process usually starts in the teen years and progresses in the second and third decade of life. It can progress pretty dramatically. Corneal ectasia is a similar process that occurs in corneas that have undergone some kind of a refractive procedure, such as LASIK, and these corneas then lose their biomechanical stability and progress to irregular shapes, similar to keratoconus. A lot of these corneas may have had underlying keratoconus that wasn't detected, and then further destabilization occurred with the laser vision correction. Either way, these corneas progress, they become irregular in shape, their vision starts to decline significantly, and may end up requiring corneal transplantation. So what does cross-linking do? Essentially, cross-linking is for these candidates who have either keratoconus that is progressive or post-LASIK ectasia. These are corneas that are not yet so severe that they already require a corneal transplant. We ideally want these patients to have acceptable vision with a rigid contact lens or with spectacles, and who are willing to and able to cooperate through the procedure and postoperative regimen. So here's a case, for example, of a 16-year-old young man who 2 years ago, the parents say he was great. He was 20/20 vision, uncorrected. And now he comes in and his vision has declined. He has this progressive astigmatism, which is pretty severe. These numbers, if you're not familiar, above 4 diopters of astigmatism sends up red flags for us. That is not usually normal to progress within 2 years to that degree of astigmatism. And when we look at their maps of their cornea, their topography maps, usually we see this inferior steepening and irregular shape in the map of their cornea that correlates with an area of thinning of the cornea in that region where the cone is, where the bulge is. So these are just not compatible with good vision because it's an irregular type of aberration of the cornea. And what happens here is the maximum steepness goes up over time, and that is indicative of progressive disease as well. So does cross-linking work for these patients? How often does it need to be repeated? Does it actually improve vision, or is it mainly for stability? And what are the methods and complications? So the FDA, this has been FDA approved now since 2016. The FDA trials for keratoconus included 11 US sites. And for keratoconus, they had 205 eyes enrolled. And in the cross-linking group versus the group that was sort of the sham or the control group, they found a significant degree of flattening of the cornea over 1 year. So 1.6 diopters of flattening in the K max over a year. And this was significantly different from the group that had sham. In the ectasia group, so this was the post-LASIK ectasia eyes, 179 eyes, they found also a significant flattening effect with cross-linking over the course of a year. And usually what we see is once we treat the patient, there's an initial area where they may look like they're getting worse, but then over a year and actually out to even 3 years, they continue to stabilize and sort of regress and stiffen and flatten their corneas. So what about vision? On the vision side, same FDA trials showed an improvement in terms of letters of improvement in the cross-linking group versus control, and that was significant. And just to flip back over in terms of the K-max, because one question we didn't answer is how often did they need to have the procedure repeated? About 5.6, about 5% in general tend to continue to progress and may need a second treatment. But in terms of vision, again, most of these patients stabilized and some improved actually as compared to the control group, and that was significant. The only FDA method that's approved right now is what's called the Dresden protocol. Essentially, we soak the cornea for about 30 minutes. Every 2 minutes, they get a drop of the riboflavin solution, and then they get 30 minutes of UV exposure at 3 milliwatts per centimeter squared for 30 minutes. They continue to get the riboflavin drops during the 30 minutes that they're getting irradiated as well. And we do this with what's called an epithelial off technique, where we remove the surface cells of the cornea, we debride or scrape or exfoliate, whatever you might call it, it sounds better to the patient. We remove the epithelium, and that's what is potentially not only painful for the patients the evening of the procedure, but can result in some of the postoperative complications we see with this procedure. So we remove the 9 millimeter epithelium centrally. Again, we drop them with riboflavin in the eyes every 2 minutes for 30 minutes. These corneas need to have a certain minimum thickness of approximately 400 microns, and then they get 30 minutes of UV exposure. Postoperatively, we put a bandage contact lens on these eyes, antibiotic drops, anti-inflammatory drops, and we see them back in a few days. Now, the complications are fairly low risk. It's a very safe procedure overall. However, they can get some corneal haze, and that's again related to the removal of the epithelium. Most of the haze tends to regress over time. But we can get infections because of that corneal scraping, sometimes a recurrence of herpetic reactivation on the cornea or bacterial infection. Overall, again, the risks are fairly low. So now there's a lot of trials looking at potentially improving the methodology, accelerated treatments so that these patients can have a quicker procedure. At this time, it's taking over an hour in the office to do these. What would be required is to increase the watts per centimeter squared. So for example, this study looked at increasing the watts to 30 milliwatts per centimeter squared and irradiating for 3 minutes. And various mixes here in terms of time in order to keep the total irradiance equal. But essentially, a lot of these studies at this time have shown that the conventional treatment is still a little bit superior to any of these accelerated protocols. That is still, the studies for that are still ongoing. There are also groups looking at not removing the epithelium and seeing if we can get similar results. Standard epithelium on using the same riboflavin solution has definitely an inferior effect. Removing the epithelium does better. 23% of epithelial on cases showed continued progression. So now there are actually variations in the riboflavin solution that's used on the cornea to improve penetration through the epithelium. This is really good for younger kids, patients who can't tolerate having their epithelium removed for one reason or another. Iontophoresis, where a small electric current aids in the movement of the riboflavin, has been used with mixed results. There's another group looking at a novel riboflavin formulation with optimized pH concentration, osmolarity, and so on to, again, improve the penetration through the epithelium. This patented CXL USA has probably shown the most promise in terms of an epithelial on technique for this procedure. This group has presented their data on 592 eyes that had epithelial on treatment with this special riboflavin, and no eyes essentially progressed over a year. So promising results, but again, a lot of this is still in research, and Dr. Jester is going to review some additional science that's behind even further innovation in this area. A couple of final exciting areas: cross-linking with the use of intact segments. Intact segments are intracorneal ring segments that can reshape the biomechanics of the cornea to make it more circular and round. These have been previously used in keratoconus, but were more of a temporizing measure because the keratoconus continued to progress. Oftentimes, these patients ended up needing a transplant anyways. But now, in combination with cross-linking and a stable cornea, these have, again, come to light and may show more promise. Cross-linking with a topography-guided PRK, which is an excimer laser like used in LASIK, to reshape the cornea. Previously, we would never do PRK or any kind of laser vision correction in an eye that had keratoconus. Now we can potentially use topographic guided PRK to normalize the shape of these corneas and cross-link them at the same time so that they're stable and they don't destabilize and become weaker. And these patients not only stabilize but can potentially have improved vision and decrease in higher order aberrations and so on. So all of this is showing a lot of promise, but corneal cross-linking is really now standard of care for progressive keratoconus and corneal ectasia. We have our current protocol right now, but again, looking at exciting developments in this area with relation to accelerated protocols, epithelium on protocols, and combination with different techniques to actually give these patients refractive improvements. So thank you, and with this, I'm going to turn it over to Dr. Jester.